There we go. Now we're recording. Hello, everyone. Welcome. Today, my name is Michelle Zenisek, and I am your moderator for today's presentation. And so I'm going to introduce Dr. Ellie Campbell. We are honored to have her here. She's a graduate of the University of Illinois, Kirksville College of Osteopathic Medicine, and the Medical College of Georgia. With over 30 years of medical experience, she is board certified in family medicine and the American Board of Integrative Medicine. An Amazon best-selling author of The Blood Pressure Blueprint and internationally acclaimed speaker, Dr. Campbell specializes in interdisciplinary collaboration, functional medicine, cardiovascular health, and takes a holistic approach when managing high blood pressure. Thank you for attending today as we gain valuable insights from Dr. Campbell's expertise. And with that, I'm going to let you take over, Dr. Campbell.
Thank you so much, Michelle. Thank you, everybody, for spending your lunch hour or early morning hours, wherever you happen to be in the world, with us. I am really excited to share with you the heart and kidney connection. But really, honestly, we know that for many of us, this begins with high blood pressure. High blood pressure is often a silent killer that stalks the heart and the kidneys. And we have new guidelines. We've just recently been reissued guidelines. When I was in medical school 40 years ago, we were taught that high blood pressure was fine if you were 160 over 100 or so, as long as you were a senior citizen. By the time I finished school, they had dropped that to about 140 over 90, and those guidelines stuck with us for many years. Recently, we've dropped that stage 1 hypertension down to 130 over 80. But there's a new category now. We used to call pre-hypertension, but now it's called elevated blood pressure. And notice the difference between the and the or words here. An elevated blood pressure is considered 120 and 80 or less. And so if you are, or more, sorry, or more, if you are above 120 and less than 80, your elevated blood pressure. A normal blood pressure is now defined as less than 120 and less than 80. So that means normal blood pressure is only 119 over 79 or less. This is a call to action to start to pay attention to the root causes of what triggers hypertension, not a call to action to write a prescription. Right? I think what we need to do is identify the people who are sneaking up into those higher ranges and start finding out what they're doing to themselves that they shouldn't be doing, or what they're not doing to themselves that they ought to be doing to get better blood pressure. We also know that our technique at measuring blood pressure is wrong. This is the American Heart Association Target BP guidelines for 7 simple steps to get an accurate and a consistent blood pressure reading across all specialties. So if we all do it the same, we can all compare our numbers. And these include, number 1, starting with an empty bladder, having your feet and back supported, not crossing your legs, supporting your arm at heart level, putting the cuff on your bare arm, not over a sweater or sweatshirt, using the optimal cuff size and not chit-chatting or even listening to a conversation, because that can add 10 millimeters of blood pressure. All of these are erroneous. I recently got to go hiking in the Himalayas, and I needed a pre-cardiac clearance from my doctor. Well, I don't have a regular doctor because I don't have any health conditions, praise God. So I had seen a cardiologist 8 years ago when I started into menopause and was having some palpitations and wasn't on enough progesterone. But my chiropractor made me see the cardiologist. So off I went. And so he's my only real doctor. So I'm in the cardiologist's office, and they're measuring my blood pressure, and they violated every single one of these. They had me sitting on an exam table, elevated up high. I had my legs crossed. My feet were dangling. They hadn't asked me to empty my bladder. The medical assistant chit-chatted with me the whole time. The cuff that she used was not an adult long cuff. It was a regular adult. I have some pretty stout arms, and it was too short. And she put it over my t-shirt. So she violated, she's a cardiology assistant, and she violated every single reading. So we want to make sure we're getting proper blood pressure readings, because we don't want to overdiagnose somebody, but we also don't want to underdiagnose them. Hypertension, after all, is a systemic disease and it wreaks havoc on our brain, our heart, our kidneys, our eyes, our aorta, our ears. And one place that's often overlooked, especially in women, is the sexual dysfunction that can come from untreated, undiagnosed, or persistent undertreated hypertension. We know that the tinier the blood vessel, the more atherosclerotic disease will play a role in reducing circulation to that organ. If it does it in the brain, we can have a stroke. If it does it in the heart, a heart attack. But if it does it in the genitalia, we tend to lose sensation. And we tend to lose the ability to dilate our blood vessels during sexual arousal, which means men will get erectile dysfunction. And often they'll come to the doctor to seek a prescription for Viagra, when what they really needed was a thorough evaluation into their oxidative stress, inflammation, blood pressure. And until somebody does that proper workup, they're going to erroneously prescribe Viagra. But this happens to women too. We get sexual dysfunction and we get reduced blood flow to our organs, and most women are very silent about it unless they're specifically asked the question. So if you have hypertensive patients, you want to talk to them about their sexual health as well as their heart, brain, eyes, kidneys. So one of my specialties is oral and systemic connections. And I really wanted to make a point on today's talk about the triangular connection between the mouth, the heart, and the kidneys. So when we talk about the mouth, we know that oxidative stress and inflammation are drivers of vascular disease. And the oral microbiome is one of the places that can drive systemic inflammation. And it does this several different ways. Number one, we know that periodontal pathogens, Porphyromonas gingivalis in particular, can raise your high sensitivity C-reactive protein. And this is whether or not you have detectable periodontal or endodontic infections. Just the presence of these bacteria, even without bleeding on probing, even without pink in the sink when you brush or floss, just the presence of these bacteria can raise your inflammatory burden. We know that LP-PLA2, lipoprotein-associated phospholipase A2, and myeloperoxidase are serum markers that are elevated when there's vascular inflammation. But there's blood vessels in the gingiva too. And so you can have elevated blood markers indicating that the patient likely has an oral contributor to their inflammatory burden. We know that bacterial endotoxins can lead to endothelial dysfunction, and that can lead to elevated blood pressure. Well, bacterial endotoxins come from gram-negative bacteria. And what are the gram-negative bacteria? They're the ones that live in your mouth. We think about them as coming from the colon because we know about gram-negative bacteria like Klebsiella and E. coli, but Agarigabacter, Actinomycetes comitans, Porphyromonas gingivalis, Treponema denticola, Tannerella forsythia, and Fusobacterium nucleatum. These are the 5 red complex bacteria that are highly virulent. I'm just going to talk about one of them, and that's Porphyromonas gingivalis. It has many virulence factors that drive it. One of them is that on its surface are lipopolysaccharides. And my friend Lindsay Bergson coined this term, little pieces of shit. And you'll never forget that lipopolysaccharide comes from gram-negative bacteria, which are found in your bowel, but also found in your mouth. PG also has an outer membrane vesicle that can travel farther than the bacteria itself and get into the intracellular space of red blood cells, white blood cells, and even brain cells. It has fimbria and pili on the outside surface of it, which lead to the ability to bind to tumor necrosis alpha and cytokines, and it has gingipanes, which we'll talk about in a second. The link to the kidneys is that we know that these circulating lipopolysaccharides that come from our gum and get into our bloodstream, go throughout our body, are inflammatory mediators, and they worsen the kidney microvascular injury. So one of the ways that Porphyromonas gingivalis, let's see if I can move this. I don't know if that's in your way, but it's in my way. How does Porphyromonas gingivalis cause disease? Well, one of those ways is by something called gingipanes. And gingipanes are proteases. I call those melting enzymes. And they're made by this oral bacteria and they are secreted through these outer membrane vesicles. These outer membrane vesicles are highly virulent and one of the major causes of periodontitis. Well, I don't care too much about bleeding gums, or at least I wouldn't if there wasn't an oral and systemic connection. But the problem is, once you have these gingipanes, these melting enzymes, we have 5 different pathways that they cause tissue damage. Number one, they degrade junctional proteins. They break down these tight junctions. Well, we know about what happens with leaky membranes, right? We talk about leaky gut all the time, but you can get leaky gums and you can have a leaky blood-brain barrier. Gingipanes support this melting of the tight junctional proteins, which then allow bacteria to spread and go further and deeper throughout the body. Way number 2, they stimulate pro-inflammatory cytokines. Gingipanes stimulate the production of chemokines and pro-inflammatory cytokines, and this leads to more systemic inflammation and then the recruitment of more immune cells, which will lead to pus at the location. We also, number 3, know that they directly impair endothelial function. They lead to the stiffening of the arteries so that they don't contract and relax in the same way that they should. This vascular inflammation obviously can contribute to cardiovascular disease. Way number 4, they disrupt the complement system. So they break down complement, C3, C4, and C5, and that inhibits our own complement system bactericidal effect. So they know, these Porphyromonas gingivalis know that if they're present, I'm going to send white blood cells and complement to the rescue to try to kill them off. Well, they break down that very defense mechanism. They also can cause the increase in complement 5A, which is an allergenic toxin that leads to even stronger inflammation. And way number 5 is they affect the clotting cascade. Gingipanes interact with fibrinogen. They cleave it, and that disrupts the blood clot formation and wound healing. Well, that's life-saving to these bacteria. Porphyromonas gingivalis wants bloody gums. It lives off of those red blood cells. It's created a way to make an environment for it to be more habitable at the cost of my bleeding gums and need to spend extra money at the dentist. So the oral microbiome is important, but you know what? What happens in the mouth doesn't stay in the mouth. And these gingipanes and Porphyromonas gingivalis get down into the kidneys. These gingipanes act synergistically with inflammatory markers to disrupt the tight junctions in the kidneys. So now we got leaky kidneys, and this compromises the filtration barrier and contributes to injury. Also, gingipanes increase vascular permeability in the kidneys, causing localized damage. So bad actors, this Porphyromonas gingivalis. We know that there's some things that we can do in our lifestyle that enhance the development and growth of an environment that fosters Porphyromonas gingivalis. One of those is mouth breathing. Because if we're a mouth breather, and once you've learned about this, you look around in airports and movie theaters and you watch the people on the airplane with their mouth open or watching the movie with their mouth open. This mouth breathing dries out the oral cavity. That lowers the pH. This more acidic environment enhances growth of pathogens rather than commensals, and you have less salivary protection to keep the mouth moist to enhance the growth of the friendly bacteria. We also know that drinking acidic beverages lowers the pH and enhances this environment for the pathogens to grow. When there's more acidity, it leads to enamel erosion, microbiome disruption, and eventually vascular stress. And we're like, well, I'm not drinking acid. Well, you might be. What if you're drinking apple cider vinegar in the morning? I don't have a problem if you put some apple cider vinegar in the morning and take a swig of it, drink the whole glass down. What I have a problem with is if you take a couple sips and set it down, take a couple more sips, and it takes you an hour to drink that. Because every time you drink it, you're dropping your pH, and it takes 15 to 30 minutes to recover the pH. If you're having another sip before that 15 minutes is up, now you're driving the acidity. The same will happen with coffee, with apple juice, with many bottled waters. If you're not checking the pH of the bottled water that you drink, you may be worsening the pH of your oral cavity. So when it comes to the heart, there's a vicious cycle because we know, of course, that the heart and the kidney are inextricably linked. High blood pressure damages kidney vasculature. High blood pressure impairs sodium and phosphate handling and furthering the hypertension. So it's a vicious feed forward cycle. The more the kidney's damaged, the less you metabolize your sodium and phosphorus. The worse those get, the more you get hypertension. And hypertension accelerates atherosclerosis, reducing blood supply to the kidneys and to the coronaries, which increase arrhythmia risk. And hypertension worsens renal flow, causing renal dysfunction that leads to then volume overload, activating the renin-angiotensin system. That can lead to cardiac hypertrophy from the volume overload and eventually heart failure as you surpass your Starling curve and you cannot contract the heart muscle anymore, which then leads to furthering hypertension. So we have a cardiorenal syndrome in which heart failure accelerates kidney disease, and kidney disease worsens cardiovascular outcomes. There are some clinical clues that you can use on your laboratory if the patient has frank proteinuria on a regular dipstick. But that's a late sign. We can find it earlier if we look for microscopic amounts of protein and compare that to the creatinine in the urine. So microalbumin is not a specific molecule, not a really tiny molecule of albumin. It's regular albumin in a microscopic amount that we can detect at the laboratory level, not usually done in the office. We look for the declining glomerular filtration rate. This really makes me mad because the labs lie to us. If you look at your average Quest or LabCorp laboratory report and it asks you what the normal estimated glomerular filtration rate is, the reference range says normal is greater than 60. That's a lie. Greater than 90 is normal, and 60 to 90 is stage 2 chronic kidney disease. We have an epidemic of chronic kidney disease, stage 2. And as primary care providers, we have a grand opportunity to reverse those stage 2s and get them back up above 90 rather than allow them to progress and march towards dialysis little by little by little, because I was taught there was very little to be done. Control their blood pressure, control their blood sugar, and watch them go on dialysis. When they get to stage 4, refer them to nephrology. And that's not fair because now we have better tools and we can use a cystatin C that will be more independent of the patient's muscle mass and hydration status and be a more accurate representation of their GFR. Also, we can look at phosphorus and uric acid, and we can detect vascular calcification. So we can look for vascular calcifications many ways. We can find it on our mammogram. We can find it on our regular chest x-ray. We can find it on a carotid ultrasound. We can find it on a coronary artery calcium score. And when we start to see vascular calcification, we know that that patient has atherosclerotic vessel disease, oxidative stress, and inflammation, which is an opportunity for us to find the root cause and intervene. And often that root cause is in the mouth. All right, let's talk about kidney and the role of vascular calcification, because the kidneys are one of the ways that our body helps clear phosphate. High phosphate becomes quite a burden in chronic kidney disease. As our kidneys become less capable of filtering, phosphorus levels rise. And the higher phosphate drives vascular calcification, drives arterial stiffness, increases our blood pressure, and worsens our hypertension. So the role of kidney phosphate in vascular calcification is that dietary phosphate from processed foods, especially sodas and ultra-processed food, influences our systemic load. And we know that we have to have salivary buffering and oral pH regulation to affect our phosphate balance. Well, we've already talked about how the mouth can become acidic. And if we have this dry mouth and we drink acid food all day, that affects our buffering capacity. We can't handle that phosphate load. So we really want to make sure that we're paying attention and getting those phosphates out of our diet. So what are some therapeutic interventions that we can have as primary care providers? Well, there are 3 that I have found really helpful to help reverse those stage 2s and sometimes even stage 3. And I've even had 1 stage one or two stage fours that I've been able to get up into stage 3 by using some of these products. So niacin, vitamin B3, sodium bicarbonate, yes, baking soda, and calcium. So we'll talk about each of these separately. Niacin in the form of vitamin B3 helps lower serum phosphate by reducing the intestinal absorption and by improving the ability of the kidneys to clear it. So that's two really important mechanisms you get from one product. But wait, there's more. Niacin also improves high density lipoprotein and it lowers VLDL and triglycerides, which often are a problem for the heart kidney patient. Finally, niacin acts as a PCSK9 inhibitor. Oh gosh, I mean, just like those expensive $1,000 a month shots? Yeah, niacin at a few cents a day can clear LDL more rapidly and puffs up the marshmallows. The size of the LDL particles can be increased, which decreases their atherogenicity. And so that then has that dual benefit in our heart kidney patients by supporting better vasculature. If we can reduce the atherosclerosis and improve the blood flow to the organs, everybody wins. So there was a meta-analysis, this is 2024 study, British Journal of Nutrition, that showed that the niacin intervention had a significant reduction in ApoB. And much of the current literature says that ApoB is probably a much, much better target than LDL for the prediction of cardiovascular disease. And so meta-analysis, many, many studies, I think 12 studies were in this meta-analysis, that showed indeed niacin lowers ApoB. Niacin treatment also improves glomerular filtration rate. Well, isn't that our goal for all of our patients to have the best possible kidney function? If kidneys are one of the ways that we eliminate environmental toxins, and our toxic overload is one of the biggest contributors to our chronic health conditions, don't we want to have healthy kidneys? Don't we want to have better GFRs? Well, experimental and clinical studies suggest that niacin and its metabolite, nicotinamide, can be used to treat hyperlipidemia and to lower phosphate levels in patients with CKD. So what about bicarbonate? It's plain old baking soda. Although, to be honest, I don't like how it tastes. So I use my bicarbonate in a tablet form. When I was in COVID, my GFR dropped into this low stage 3 CKD, dropped into the 40s. And so I used bicarbonate for several months after COVID to help rejuvenate my kidneys. It helps correct the metabolic acidosis. That's obvious. It's a base. If I'm acidic, I'll add a base. I'll pull my pH up. But this alkalinization also allows the kidneys to clear the phosphate easier, so it reduces phosphate resorption, thereby protecting bone and muscle. Because if you soak a chicken bone in vinegar, it turns to rubber, right? Because the acidity leaches the calcium out. Well, we don't want the acidity. We want to be more neutral. So alkalinization towards neutral can protect our bones and muscles. Bicarbonate also makes the vasculars more compliant, the blood vessels, makes them a little easier, less likely to be hypertensive when the pH is better. So oral sodium bicarbonate dramatically reduces systolic and diastolic blood pressure. By treating the metabolic acidosis with bicarbonate, we can slow the rate of decline of kidney function and improve vascular endothelial dysfunction in patients, improve their endothelial function in patients with CKD. What about calcium? Well, calcium acts as a phosphate binder in the gut, especially when taken with a meal. So this obviously to keep that calcium in the bones and teeth where it belongs and not in the blood vessels where it doesn't, if we can prevent vascular calcification, that would be a good thing. You have to be balanced because it's easy to become hypercalcemic. And I've done that to a couple of patients, given them calcium. Calcium citrate is maybe a little bit gentler on this hypercalcemic continuum than is calcium carbonate, which is what's Tums. Or we like the Genexa brand of Tums. It's still calcium carbonate, but it's cleaner. It doesn't have the artificial colors. It's got fruit flavorings and fruit colorings in it. So if you're going to use a calcium carbonate, use Genexa, but some patients will require calcium citrate. And if you're going to recommend calcium, be careful about the dose. Most kidney patients will handle easily up to about a gram, but more than that, you have to be really careful and watch their kidney function, including their cystatin C, their phosphorus, their calcium levels. So calcium-based binders are a standard treatment for hyperphosphatemia, but need to be proceeded with caution. So what if you could find an all-in-one? What if you had niacin, bicarbonate, and calcium all in one product? That would be nice, right? Oh gosh, the number one reason why patients don't stick with niacin is because it causes a flush. Well, we like to say, embrace the flush. Know that it's improving your blood circulation. Know that every time you see the flush of pink on your cheeks, you're getting more blood to your brain, you're getting more blood to your heart, more to your kidneys, more to your pancreas, more to your sex organs. So we want that niacin flush. It's good for us, but some people find it unpleasant. Well, it turns out that quercetin, which is found in relatively high amounts in apples, apple skins, and capers, has a derivative from Sophora japonica called isoquercetin. And that very significantly mitigates that flush. So if we combine all those things together, you can find it in a single capsule taken twice a day to get all three and now all four things together in one capsule. So I say when it comes to clinical integration and prevention for patients, patients need to have better oral health. We as primary care healthcare providers need to include in our conversation with the patient, how is your oral health? When was the last time you went to the dentist? Do you have pink in the sink when you brush or floss? Do you use a water pick? Do you use a electric toothbrush? When was your last visit to the dentist? Do you know how deep your pocket depths are? Because when we express an interest and we reconnect the mouth to the rest of the body, the patient with better oral health will have better systemic health and will have better blood pressure control. Of course, we also have to talk to them about their lifestyle and diet. We want to make sure they're on a plant-forward diet, mostly plants. Yes, they can have animal protein if they want, but they have to limit the portion size, and it shouldn't be the biggest thing on their plate. A 16-ounce steak is 4 meals, not one. We want to make sure they get phosphate additives out of their diet. We want to make sure that we have measured and tested their oral pathogens. You can do a simple spit test in the dental office or the medical office to screen for these AAPG, TD, TFFN, red complex bacteria. And we want to look at their acid load. We want to look at the pH of their urine, maybe have them do some home pH testing of saliva or urine. For clinicians, we want to make sure that we are checking the mouth, the heart, and the kidney together. Make sure that you've done an assessment for your patient, not only an EKG, but have everybody over the age of 40 get at least one coronary artery calcium score, know what you're up against. Look at their kidney function. If their GFR is anything less than 90, please also do a cystatin C, a phosphatiduric acid. Make sure that we know these numbers. Get their spit test, measure their blood phosphate, look at their advanced lipids, not just their total cholesterol, HDL, LDL, but also what is their ApoB, what's their lipoprotein little a status, what is the size of their lipoprotein particle number, of their LDL particle numbers. And we want to look at urine for microalbumin as well as for markers of oxidative stress, such as F2-isoprostane. And we want to be careful using niacin, bicarbonate, and calcium judiciously, but they can make a tremendous improvement in our patient's kidney function. Because hypertension doesn't just haunt the arteries. It starts in the mouth and it echoes through the brain, the heart, and the kidneys. So my call to action for you is that the future of health prevention lies in oral systemic connection. If you're a dentist, do you have at least 2 primary care providers on speed dial in your phone? If you're a medical doctor, do you have at least 2 dentists on speed dial on your phone so you can text, call, ask questions, and refer? There is no health without oral health. We have to seek the interdisciplinary collaboration of medicine and dentistry in order to break this cycle of inflammation and phosphate overload. Most of the time, the patient does not have an oral health problem. They have an oral systemic problem. And we both need to work together to help eradicate that. We want to use judiciously our dietary restrictions. We don't want to over restrict. We don't want to take every patient off sodium. They don't all need it. Most patients will need more potassium than they're getting. Most patients will need more magnesium than they're getting. Most patients will need a little less animal protein than they're getting. And when we do these things together, we can save kidneys. So my takeaway for you is that a healthy mouth leads to healthy arteries, which lead to healthy kidneys, which control your blood pressure, which lead to a healthier brain, eye, heart, kidneys, genitalias, and more. My final question for you for the week is, what do pediatric orthopedic surgeons and nephrologists have in common? Kidneys. Ha 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 ha. So I am the author of The Blood Pressure Blueprint on Amazon. This is a book about oral and systemic health and therapeutic lifestyle changes wrapped up in a cover on blood pressure so that people will actually want to pick it up and read it. I'm very proud to say that I've been an Amazon bestseller for many, many, many months. And it's an easy read. My intended avatar is a patient, not a provider, but almost everybody will find useful tips, tricks, and tools in there for themselves or a loved one. That QR code will take you straight to Amazon, or you can just Google my name and the blood pressure blueprint and you'll find it as well. So with that, I guess we can take a few questions. I think I stuck on our time frame pretty well, and I'm
Yeah,
happy to.
so for just so everyone knows, there's a Q&A box. If you want to put a question in there, I do have some questions here. Are there any supplements other than the niacin and bicarbonate that helps to be proactive in preventing mouth, cardio, and kidney disease?
Yeah. So I guess the answer is yes, there are many. We know that controlling blood pressure is important. So almost all of my patients, I measure serum magnesium levels. You want to get to the upper quartile of the levels of magnesium to make sure that that is adequately repleted, because hypomagnesemia will cause hypertension. Low potassium levels as well. Many patients, especially elderly, are put on diuretics like Lasix, and their doctors know that that will deplete potassium, and they'll often give them a potassium replacement, but they often won't check or replete magnesium. So when I was training, it was K above 4 and mag above 2, and I've even pushed that a little higher, tried to keep my potassium in and around 4, but my magnesium up around 2.2 to 2.4. So that's one. There's many supplements that are on the market to help for oral health. One is called Tooth and Gum Tonic. It's an all-natural red thyme, cinnamon, aloe. There's a bunch of all-natural ingredients in it. It helps clear some of those red complex bacteria out of your mouth. So does a product called Stella Life. Those are the only two mouthwashes that I would recommend anybody ever use to try to treat the oral problem. But recognize it's often an oral systemic problem, because gums talk to gut and gut talks to gums. We swallow 1/2 to 2 liters of saliva every day. So if we're swallowing those bacteria, some are getting past our stomach acid and into our gut, and then through this circulation, we get back into our salivary glands through our gut. So bacteria go both ways. They also travel up and down our vagus nerve and throughout our bloodstream. So we can't just treat an oral problem. Sometimes we have to treat an oral systemic problem. Other supplements, I really do like hawthorn, and I really do like, I don't know why this does not want to stick in my brain. It's pink, it's a plant, and it helps blood pressure, and it's so tasty, and we do it in the summertime, and its name is escaping me. Oh, I hate that when my brain goes on glitch. It'll come to me in a second. And you make a tea out of it, and it's a lovely way to treat hypertension with an all-natural remedy for blood pressure.
Okay. Um, Amanda is asking, what is the best combination supplement?
Um, Kidney Defender is its name.
Okay. And Roz is asking, what's the deal with coenzyme Q10 for oral health relative to your protocol for oral health?
Yeah, so CoQ10 is really helpful. CoQ10 has been shown mostly in the studies to it's hibiscus flower. That's the pink one I couldn't think of. CoQ10 has been shown mostly in the dental world to have a topical effect, but it does control blood pressure a little bit, a few points, and it also helps heal and seal the gums when they're inflamed from gingivitis or early periodontal disease. Does so best topically, but we use it orally as well.
Okay. And Ed is asking, you mentioned an all-in-one supplement that has niacin, calcium carbonate, and sodium bicarbonate. Where can I find it?
um, if you just Google Kidney Defender, you will easily find it. Michelle, is there a different website you want to send them to? Health Defender has all those. They have several other products besides Kidney Defender or products in development. So Health Defender is the company that sells Kidney Defender.
Okay. Okay. And oh, okay, so he got his question answered. Okay. So let's see here. You talked about oral rinses. How do you get a pH test in your mouth? Self-test or the dentist?
Either or. Some dentists will have a probe, like a thermometer probe that you stick in your mouth and measure, but pH paper, you can buy a whole roll of it for about $5 off Amazon. You just want to get the one that has a fairly narrow pH range, like 5 to 10. Um, and yeah, you just drool onto it or stick it in your mouth. You're not supposed to suck on the paper because of the chemicals in the paper, but you can get a big glob of spit on the tip of your tongue and just touch it and compare it to, it's a colorimetric test. So you just hold it up against, and is it a little green, a little more yellow, and just track it through the pH. You can use the same test strip to stick in your urine, unused, like one for your mouth and one for your pee.
Okay. I believe that's all we have for questions.
Okay.
Unless anybody has any last minute questions they want to put in.
Yeah, the only thing that I would like to add is it's hard to find a medical doctor and a dentist who are equally enlightened. And this is very new cutting edge stuff, really, in the last couple of years. And when you look at medical information over time, 50 years ago, the amount of medical information doubled every 25 to 50 years. Now, medical information doubles every 73 days. So it's super hard to keep up. And that's no fault of the practitioners. They're in their office doing the best that they can. But the International College of Integrative Medicine, the American Academy for Oral and Systemic Health, the IAOMT, we all have find a practitioner's links where you can find, at least start your search to search for a oral systemic expert who will be able to speak the language and have a referral source to get you there. Furthermore, I ask you to employ your own primary care provider and dentist to jump on this bandwagon. So if your dentist isn't looking at pH, isn't familiar with the ways that your mouth can affect your heart or your kidneys, that you ask them, when I come in 6 months, would you have considered going to a conference to learn about these things? Because they're important to me. I'd like them to be important to you as my healthcare professional.
Okay, so we have a few more questions. But
Sure.
before I do that, I want to tell everyone you can go to healthdefender.care for Kidney Defender and you can find that there. Um let's see, Dr. Paula Rhodes says nattokinase for vascular health and red yeast rice.
Yeah. Absolutely. Those are two also great products. We use a lot of nattokinase as well as high dose vitamin K. When I see a patient that has established atherosclerotic vessel disease, we put them on nattokinase. This is an enzyme that comes from natto or fermented soybeans, and it's an enzyme that literally will chew up the plaque. I personally, 4 years ago, had 1.3 centimeters worth of plaque in my carotid arteries. And I recently had a coronary scan and a neck ultrasound with zero plaque. So I was able to reverse all that plaque with the use of nattokinase and vitamin K predominantly. I also switched my diet a bit. I found some food sensitivities that were driving my inflammation. Have to avoid gluten, dairy, and oats. Keep those out of my diet, and that helps lower my inflammatory burden, making my arteries healthy. Red yeast rice is the naturally occurring statin that we find in from plants. So it acts on the HMG-CoA reductase pathway, the same pathway that Lipitor and Crestor and Pravastatin all work on. It's not as strong as the prescription drugs. It will lower slightly. What we don't have with red yeast rice is outcome studies. And I don't want to treat cholesterol because treating cholesterol doesn't save lives. What saves lives is treating oxidative stress, inflammation, ApoB. We have numbers that show that these things will make a difference. But just treating a cholesterol to get it from higher to lower isn't going to do anything for the patient. We've got to get the inflammation down because normal cholesterol will travel through the blood vessel wall out the other side into the lymphatics and get recirculated. But if there's a lot of static in the artery wall, which is caused by oxidative stress and inflammation, then the cholesterol begins to stick. And the smaller and stickier the particle numbers, the more corrupted that cholesterol is, the more that atherosclerosis is likely to develop and thicken up in the artery wall, causing the plaque that we can measure on a test. We're not sure that red yeast rice changes that. In theory, it should, but we don't know for sure. So I do have some people who refuse statin drugs. Most of the time, if they're indicated, I can convince them to take them 2 or 3 days a week. They don't have to take them daily, especially because Crestor has such a long half-life. You can get away with that. And I still get these continuous reversals in atherosclerotic plaque, which even I personally haven't seen with red yeast rice. So yes, it will lower cholesterol, but I don't know if it does the job enough to recommend it, certainly not routinely.
Okay, so another question. Well, before I do that, I'm going to say that once this webinar is done, you'll get an email. Everyone's going to get an email with all the answers to questions and the link to Dr. Campbell's book, along with other links as well. So, um,
Awesome.
but the next question from Amanda is, how can we advocate for additional lab testing?
Just have to ask for it. In the unlikely event that your doctor will not, absolutely refuses to order it, you can often self-order through Function Health, through Quest on Demand, LabCorp on Demand. You can just go in and say, I would like a lipoprotein little a and an ApoB, please. Also check my cystatin C. Almost all those labs now are available on demand without a doctor's order.
Okay. And another question here is, what are those two orgs to check with for an oral systemic expert?
Oh, AOSH, AAOSH.org and IAOMT.org.
Okay. And then Ed has a few things typed here. He says there's a more bioavailable version of COQ10, but a lot more expensive. He says it's called UBI or
Ubiquinone.
yeah. He's asking if he should switch.
Maybe. Um, I measure CoQ10 levels on my patients. So if they get up into the upper quartile of the reference range, they can stay on what they're on. If they're not getting there, then we switch them to the more expensive one and see if we get there. There's also some genetic polymorphisms. If you want to take a really deep dive into this, Intellex DNA will do a $1,500 blood test on, or sorry, cheek swab test to look at your genetics and see if you're one of those people that has to spend the money to get the ubiquinone instead of the ubiquinol form.
Okay. And he's also asking, have you heard of SBLT-2 for CKD?
No, SBL. I don't.
Yeah.
Sorry.
Okay. Oh, he says it's SGLT-2.
Oh, SGLT2s. Yeah, so that's a class of medications that we use for managing blood sugar. And it seems like they probably will also improve kidney function. So too, by the way, will the GLP-1s. That's the Ozempic class of drugs, in part because of how they reduce the oxidative stress caused by the higher blood sugar readings. So yes, there is a role for those medications. They have to be doctor prescribed.
Okay. And let's see here. Another question would be, should we take statins?
Sometimes, in my practice, we use statins for anyone who has established atherosclerosis until their scores are zero or everything is calcified and nothing is soft or heterogeneous. Once we've matured and healed the plaque to the point where it's not advancing and it's shrinking and it's solid and it's stable, I don't think there's a reason for statins to continue, but most people are on them for a while, a few years, a decade maybe. Um, and if they don't make any effort to improve their oral health, optimize their nutrition, oxidative stress, and inflammation, they'll never get off their statin. And it's an insurance policy against events.
Okay.
All
I
right.
believe that's all for questions.
Excellent. Thank you. I have another meeting I need to run off to. So thank
Okay.
you, everybody, for your time and attention. I hope you learned a few things and happy Halloween.
All right. Thank you very much, Dr. Campbell.
You're so
Thank
welcome.
you, everyone, for attending. Bye-bye.
Bye now.